Hello, there's an anti-androgen used all over the world in feminizing hormone therapy, but not in the United States, and the way we think about it has changed dramatically over time. I'm Dr. Dave, your transgender health and hormone specialist with 30 years in the field. Let's talk about cyproterone acetate. Cyproterone acetate, it works, but the dose matters. CPA is one of the most commonly used anti-androgens in feminizing hormone therapy outside the United States. And first, the important American disclaimer. CPA is not FDA approved and is not available by prescription in the United States, like I mentioned before. So if you're in the US, this is mostly an educational video. But if you're outside the US or you follow international hormone care, this medication really does matter. CPA does two things at the same time. First, it's a very strong progestin. That means it tells the brain to turn down LH, the signal that tells the testes to make testosterone. So testosterone production drops. Second, CPA blocks the androgen receptor, so it lowers testosterone production, and it also blocks some of the testosterone that remains. That's why it can be so effective. For many transfeminine patients, CPA can lower testosterone very reliably. It's oral, it's usually once daily, and it's inexpensive in most countries. And when it's used carefully, it can be a very useful medication. But here's the part that's changed over the years. For years, people were commonly prescribed 50 milligrams a day, sometimes even as high as 100 milligrams a day. That was pretty much standard, normal. That was what a lot of clinicians were taught. Now we know for gender-affirming care, most people do not need doses anywhere near that high. Modern studies suggest that low doses, often around 10 milligrams daily, sometimes 12.5 milligrams daily, depending on the tablet size and local practices, can suppress testosterone about as well and as much as higher doses for most people. That's the key lesson. More CPA does not always mean better. Sometimes it only means more exposure and more risks and more side effects. The biggest risk we have to talk about is the meningioma. A meningioma is a tumor that grows from the lining around the brain and spinal cord. Most are benign, but benign does not necessarily mean harmless. If it's pressing on the brain, the optic nerve, or other important structures, they're all pretty important up there, it can become a very serious problem. CPA has a known association with these meningiomas, and the risk appears to rise with cumulative exposure. In plain English, a higher dose, longer time, more total medication over your lifetime equals higher concern. That's why the low dose shift matters so much. It's not just about avoiding fatigue or side effects today, it's about reducing unnecessary lifetime exposure. CPA can also affect the liver. Serious liver injury is uncommon, but it is real enough that liver enzymes should be monitored, especially early in treatment or if the dose is higher. CPA can raise prolactin. Usually that's mild, but it does matter if prolactin gets very high, if there are headaches, vision changes, nipple discharge, or other concerning symptoms. It can also affect mood and energy. Some people feel fine on it. Some people feel flat, depressed, tired, or emotionally blunted, and that's no fun. And when that happens, it deserves to be taken seriously, not just brushed off. There may also be some mild concerns about blood clot risk, especially when CPA is combined with estrogen, as it is with most trans women, and especially with other blood clotting risk factors. That does not mean everyone on CPA is in danger. I'm definitely not saying that. It means the whole risk picture: age, smoking, migraine, clot history, estrogen route, dose, and other medical conditions need to be taken into consideration. So is CPA bad? Absolutely not. CPA is not a bad medication. I want to keep saying that. It's a powerful medication, and powerful medications deserve respect. Actually, all medications do. The benefit is that CPA can suppress testosterone very effectively, often with a simple daily pill. For many people around the world, it has been a major part of successful feminizing therapy. The risk is that the old high-dose habits expose people to more medication than many of them needed. So the message is simple. If you're on CPA, know what dose you're taking. If you're on 50 or 100 milligrams a day, please talk to your prescriber about why they're choosing to leave you on that high dose. Don't stop it suddenly without medical guidance, but do have the conversation. Can your testosterone be controlled on a lower dose? Are your liver enzymes being checked? Has prolactin been considered? Do you have headaches, vision changes, new neurologic symptoms, or a history of a meningioma? Those are not panic questions. They're simply good medical care questions. Cyproterone acetate works, but in 2026, the goal should not be the biggest dose. The goal should be the lowest effective dose that gets the job done safely. That's what we call informed consent. Thank you for sticking with me through this. I hope you enjoyed it as much as I enjoyed bringing it to you. It was a recommendation on my comment section. You always give me a warm and fuzzy feeling in my tummy. Let's remember to love, support, and protect each other. Meow meow.